Very good evening to everyone. I would like to welcome everybody to the second episode of the APSC Hot Topics in Cardiology webinar series. Today's episode is on coronary intervention, and I'm happy to introduce my co-chair, Dr. Vishnu Aditya from Jakarta Heart Center in Indonesia, a very good friend as well. And for our panelists, we are pleased to introduce a distinguished panel of panelists, Dr. James Shi from Liverpool Hospital in Australia and Dr. Lam Ho from Tun Min Hospital in Hong Kong. Our speakers are Dr. Tan Chin Tin from Sarawak Heart Center, as well as Dr. K. Yen Shan from National Heart Center Singapore. We'll talk a bit about their talks later, but in brief, Chin Tin is going to talk to us a little bit about DCBs and Yen Shan on coronary microvascular dysfunction. Just a bit of housekeeping. The contents of this webinar is copyrighted by the APSC, but the views and opinions are expressed of that of the faculty members. The webinar will be live streamed on Facebook and YouTube pages, and you can kind of re-access them later if you are keen to rewatch the episodes. I just want to highlight that if you have any questions during the discussion session, you can click on the Q&A button at the bottom of the screen, and then you can post your questions and we'll try to discuss them. Just a quick shout out, episode 3 is next month. It's on cardio kidney metabolic diseases, very interesting talks as well. So do tune in on the 5th of November. And another shout out to APSC 2026 in May next year is conjoined with TSOC. So we hope to see you there. So without further ado, I would like to introduce our first speaker, Dr. Tan Chin Tin, once again from Sarawak Heart Center in Malaysia. She's really going to talk to us about DCBs in more special scenarios, so in ACS as well as de novo large vessels. So I'll hand over to you, Chin Tin.
Yeah, thank you, John, for the kind introductions. So let me share my slide. Okay. Can see my slide?
Yes, we can.
Okay, so my topic given today is DCB in an extended scenario, ACS and de novo large vessel. So first I need to do my disclosure. My default PCI strategy is drug-coated balloon, but I'm not a die-die DCB person. I do not hesitate to put in a stent if there is a need to. So this is a case that we did a DCB before. It's a patient, it's a relook angiogram at 6 months. It's a 64-year-old gentleman presented with unstable angina. And from this angiogram, can you identify where is the culprit lesions? Where is the original lesions? It's pretty good, right? So you can't identify where is the lesion. So in order to achieve this kind of good result, we need to have a good lesion preparations prior to DCB implantations. First, in order for optimal lesion preparation, we need to choose what type of balloons should we use. So it depends on the lesion complexity. In simple lesions, semi or non-compliant balloons will do already. In complex, such as fibrocalcific lesions, sometimes we will choose scoring or cutting balloons. In very severe heavily calcified, sometimes we'll upfront rotablation, atherectomy, OAS, or lithotripsy. And how to choose between the balloons to vessel? It is with a ratio of 0.8 to 1. So balloon to vessel ratio, if you are using angiographic, it is 1 to 1. But if we are using intravascular imaging, if you are using vessel diameter, is 0.8 to a balloon size to vessel diameter. And if you are using a lumen diameter, is 1 to 1. Lumen diameter is 1 to 1 ratio. And during the balloon inflation, you should up the balloon slowly, like 2, 4, 6, 8, 10, 12. And then when you inflate, you tend to have doing the long inflation time, 20 up to 60 seconds. The longer, the better, actually. Some of the operators doing 90 seconds also. And slow deflations. Patient is the key for DCB success. And after these balloon preparations, there are three criteria we need to look at. First, there must be a TIMI flow. If there is a dissection, there must be non-flow limiting, type A or B, but not C to F. And residual diameter stenosis less than 30%, sometimes we assess up to 50% stenosis. And during DCB PCI, DCB length must be 2 or more millimeter beyond the initial pre-dilatations. Make sure we don't have any geographic miss. And inflations for DCB should be at nominal or +2 nominal. Inflation durations, 30 to 60 seconds, sometimes some operator up to 2 minutes. DCB, but what you need to remember, DCB is not a dilatation balloon. It's just to deliver the drug to the vessel wall only. And remember the case just now, you cannot identify where is the lesion. This is the angiogram during the index procedure. You can see there's a very tight stenosis distal circumflex. And for the LAD, there's very tight stenosis proximally. RCA is normal. And after LAD, we did a balloon pre-dilatation using a semi-compliant balloon, 2, 5, 15, up to 14 atmosphere, slow inflations. Be patient. And after that, this is an angiogram after the semi-compliant. Mid-LAD is still residual 60 to 70. There's presence of type B dissection. TIMI flow is 3. There's possible myocardial bridging at the mid-segment. And the operator decided to further balloon dilatation over the mid-segment, 30-15, using a semi-compliant balloon. And this is the angiogram after balloon dilatation. Type B dissection, residual stenosis about 20 to 30%, and most important, TIMI flow. So treated with DCB, mid to distal LAD 3.0, and then proximal LAD 3.5. And the duration of dilatation is about 60 seconds. And you can see there's presence of type C dissection. Although there is TIMI flow, residual stenosis over the mid about 20%. The operator decided to accept this result because the flow is still TIMI. Proceeded with PCI to the circumflex. Pre-dilated using a semi-compliant balloon, 2.015, slow inflations, and this is the result. And you can see here that the dissection over the LAD is still there. And minimal dissection, TIMI flow, residual about 10 to 20%. And treated with DCB, 2.25. So for the circumflex TIMI flow, residual very minimum, 20%, type B dissection. But there is a type C over the LAD. But the flow is TIMI, and this is up 20 minutes after the LAD PCI. So the operator decided to accept all the results. So this is angiogram before, after PCI, and this is during relook angiogram at 6 months over the LAD. And you can see type C dissection actually healed. For circumflex, pre and after the DCB, and 6 months after, actually, there is a luminal gain for circumflex. So DCB strategy in this case leaving nothing behind, avoid long DAS that lead to future ISR. So what is your level of tolerance for dissection? You can see just now type C dissection, we also accept the result. This is another case, 80 years old gentleman, very old, presented with anterior STEMI. You can see the LAD is very calcified. There is presence of 90% stenosis over the proximal, and there is another lesions from the mid to distal up to 90%. Diagonal 2, also very tight stenosis. Circumflex left main RCA is quite normal. So because elderly, maybe we proceed with the PCI. PCI put the proximal LAD using a 3520 DCB after balloon predilatations. And mid to distal, we treated at 225, 30 DCB. You can see there's presence of type C dissection, residual about 30%, and the floor is about TIMI 2 to 3. And in this case, our tolerance for dissection is very high. The reason behind is this is a very long diffuse calcified lesion. There is no landing zone for us. We might need to stand into the left main until the apex of the LAD. And pushing down the DS to the distal LAD might be challenging in these cases. And furthermore, the type of dissection in this case is the one with in and out. So there's inflow and there's outflow. You can see there's a dissection, a linear line. So we think that this is an acceptable dissection for us based on our experience. And there are another type of dissection where there is in but no out. So with this in but no out, there is a risk of intramural hematoma. As you can see here, there is intramural hematoma from here, and therefore there is a luminal compromise distally. So in this type of dissection, there are high risk for acute vessel occlusions. We look angiogram at 6 months. You can see the flow improve, TIMI 3 flow. There's presence of 40 to 50% stenosis at the mid segment, and all the dissection heal. We're leaving this kind of 40 to 50% stenosis, and patient is asymptomatic now. And there is an old Chinese proverb, 上得善多终于虎. That means we did so many DCB cases, accept all the dissection. We have certain time, we will have acute vessel closure. This is a 60 years old gentleman presented with positive EST. Left main circumflex RCA normal. LAD, there's presence of 70% stenosis at the mid. Look like very simple lesion for us. And of course, DCB strategy. Lesion preparation after Scoflex 3.0, treated with DCB 3.0/40. As you can see here, there is presence of type C, type B to C dissection at the distal segment. Okay. So the operator, again, he decided to accept this result. But 15 minutes later, patient complained of chest pain at the recovery, and ECG shows hyperacute T wave. You show that the flow distally is TIMI 2, and there is presence of intramural hematoma distally. Immediately, we are using a cutting balloons and treated with stent 2534. The flow look like improved. We accept this result and relook angiogram at 3 months. The flow distally improved. There's presence of stent. And yeah. So sometimes bailout stenting is needed if you in doubt bailout stenting. So my advice for dissection, everyone's tolerance to dissection is different and is case to case. First thing in dissection, you need to ask yourself, how is the flow? Is it a TIMI 3 flow? If there is any doubt, proceed with bailout stenting. You can keep the patient on the table for a while and looking for any vessel or recoil. Sometimes people will keep 15 minutes to look for any recoil. If any recoil, bailout stenting. And intravascular imaging and functional assessment might be helpful in certain cases. Next, I will talk about DCB in ACS. 44 years old gentleman, very young, presented with anterior STEMI, proceeded with primary PCI, LAD proximal occluded. Circumflex and RCA is normal. So wire down to the LAD after thromboaspiration. So we did a balloon predilatations, semi-compliant balloons. And this is after balloon dilatation. There's still some haziness intraluminal, minimum dissections, residual about 30%, TIMI 2 to 3. Do we have any good lesion preparations? So the operator decided to put in a DCB. 275/20. And this is the final angiogram. DME 2 to 3, residual about 40 to 50. And there's intraluminal possible thrombus. And relooked angiogram 3 years later. Actually, the thrombus resolved. And minimum stenosis actually. And this is the beauty of leaving nothing behind in young patients. So according to the second report of Asia Pacific Consensus Group, DCB treatment for acute myocardial infarction, beside that optimal lesion preparations, there is the additional step of assessing the thrombus burden. If there is a huge thrombus burden, it will suggest you to do the thrombo aspirations. If there is minimum thrombo burden, you can proceed with the balloon pre-dilatations. And they have 2 studies looking at the DCB in MI, one in STEMI, one in non-STEMI. And both studies shows that DCB treatment is non-inferior to stent in STEMI and non-STEMI. Can I treat all the lesions with DCB in ACS setting using drug-coated balloons? So after treating the culprit or proximal to the culprit, can we treat all the lesions with DCB? So this is another case. 50-year-old gentleman presented with inferior STEMI, proceeded with primary PCI. You can see the vessel of the circumflex is very aesthetic. LAD, minimum disease, minor, and RCA, proximal, maybe there is a 70%, and distally, there's about 90%. So sequential balloon pre-dilatations, 275 semi-compliant balloons, and after that, using a 35 NC. You can see the flow distally impaired. There's a slow flow, and there's a possible distal embolization of vulnerable blood, mostly from this area, distally. So proceeded with thrombo aspiration, IC nicardipine, and tirofiban. DME flow improved. So decided IV tirofiban 24 hours, relook angiogram 2 days later, and continue with ACS treatments. And this is a relook angiogram after 48 hours. You can see there's still residual 90% stenosis. But what I want to do now, no more balloon pre-dilatation, of course, because there's a risk of slow flow, and perhaps I can do with proceed with direct stenting with intravascular imaging guidance. So direct stenting, mid to distal RCA, and proximal LAD RCA, I treated with drug-coated balloon. Mid to distal, 4O, and then overlap with 4.5. And proximally, I treated with DCB, 4O20. And this is the final angiogram. Even though proximal, there is a type B dissection, the flow is DME3. I accept the result. And circumflex, treated with DCB, 4O20 after balloon, after lesion preparations. And in same patients, in different lesions, maybe we can treat with drug-coated balloons. So DCB in PCI, DCB PCI in ACS is feasible if there is a good lesion preparation, but we must remove the thrombus. Treat with stent if the patient is hemodynamic unstable, there is high risk of arrhythmia, and there is high risk of slow flow. And plug morphology is very important because in one vessel, there might be a vulnerable plug. Another part of vessel may be a fibrous plug. And DCB can be used in fibrous lesions. So DCB in large vessel, specifically in aesthetic vessel. 61-year-old gentleman, lady, presented with non-STEMI. You can see distally, there's one lesion over here. The vessel is very aesthetic, huge, 80% stenosis distally. Balloon pre-dilatations, 3.5 NC. Normally, we will downsize our pre-dilatation balloon. And after that, we treated the lesion using a DCB 3.5. And this is after DCB, DME3 flow, minimum dissection, residual about 20. And relook angiogram at 10 months. It's pretty good. Minimum minor irregularity. So how about osteoproximal LAD lesions? 58-year-old gentleman, non-STEMI, RCA is minor disease. Left man, minimum, normal, about 50% stenosis and occluded distally. LAD, presence of osteoproximal lesion up to 90%. So how you want to treat these lesions? imaging assessment of the distal left main and osteo-LAD, precise osteo-LAD stenting under IVUS guided. So we must using a 7 French guiding, and osteo-LAD plug burden must be less than 50% in order for you to do the precise LAD stenting, osteo-LAD stenting, and plug burden at the distal left main must be very minimum, or provisional left main LAD stenting. Or another option, osteoproximal LAD DCB PCI using IVUS guidance. In this case, pre-dilatation using a semi-compliant balloon, 2.5 and then 3.5 NC. Okay, look like there is a type B dissection. The floor is TIMI3. So treated with DCB, 3.5 40 for 60 seconds. And this is the angiogram after DCB. The floor is a TIMI3. There's presence of type B dissection. We accept this result. And this is relook angiogram at 6 months. You can see the dissection heal and minimum stenosis. How about left main LAD bifurcation PCI? 65 years old lady, heart failure will reduce ejection fraction. Left main is tapering with 50% stenosis at the distal. LAD is very diffuse disease from the proximal to the mid. Diagonal also disease, 90%, D1, and D2 about 60-70. Circumflex moderate lesions, and RCA is occluded. So it's a triple vessel disease, heart failure, reduced ejection fractions, diabetes patients. Our revascularization strategy is either CABG or multi-vessel PCI, but this patient refused CABG. So proceeded with PCI to the RCA, bilateral puncture, and then treated with stent. Okay, good result. Then how about PCI to the left main LAD? There are the possible challenge is left main LAD and LAD diagonal D1, D2 bifurcation lesions. There's double bifurcation, and the left main LAD Medina is 110, and LAD diagonal D1 is Medina 111. So is this bifurcation simple or complex? For left main LAD, the circumflex stenosis is less than 70%, lesion length is less than 10. So it's a simple left main bifurcation lesions. For non-left main LAD diagonal 1, the stenosis for D1 is more than 90, and there is a complex bifurcation over the non-left main bifurcations. So now, PCI strategy. For left main LAD, no doubt, provisional stenting. How about the non-left main? Is it 2 stent? Upfront, 2 stent strategy. So we can choose either 2 stent strategy, decay crush, hybrid stenting, main branch stent, side branch DCB, or DCB both main and side branch, or DCB all the lesions, left main LAD, LAD diagonal. So in this case, I choose all DCB. So sequential balloon pre-dilatation over the LAD and diagonal. And this is the result after pre-dilatations, TIMI3 flow, type B dissections, and treated with DCB. Mid-LAD, DCB 3.0, and overlap with another DCB 3.5-20 proximal LAD, diagonal 2.25 DCB. You can see there's a type B to C dissections at the proximal LAD. The flow is good, TIMI3. So this is a pre-PCI after DCB, and this is 6 months during follow-up. You can see the dissection heal. And from another view, aerial corridor view, before, this is after DCB, and this is 6 month follow-up. And your dissection over the proximal is healed. So this is a systemic review and meta-analysis of all the RCT comparing DCB versus stent in large vessel. So it shows that in de novo large vessel, DCB has comparable mass and TRF rate. And in conclusion, DCB PCI in large vessel, DCB simplified the complex lesions. And in athletic vessel, there is no worry about the stent size, whether 7mm or 8mm. There's no risk of stent malopposition. And normally, balloon pre-dilatation, we are choosing the ratio of 0.8 not one-to-one. And DCB PCI avoid complex bifurcation PCI. Do you have any DCB patients come back for restenosis? Yes, we do have. So this is a 51-year-old gentleman, unstable angina, only LAD lesion, 90% at the osteoproximal. After lesion preparation, treated with DCB, 3-5-25. You see that the flow is good. There is minimum dissection. Residual about 20 or 10. And 9 months later, patient presented with non-STEMI. You can see there is lesions at the proximal, about 80%. So treated with stent, 3-5-22. Further history for this patient, he defaulted treatment for 6 months and still smoking. And therefore, the success of procedure is not only an optimal PCI result. Patient education and compliance also play an important role. Another lady, 42 years old, inferior STEMI. Left main, normal. Circumflex is recessive. There's some disease, 50% over the mid to distal. LAD, 70% stenosis at the proximal and at the mid segment also. RCA, there's presence of 80% stenosis at the proximal to mid and distal about 70%. So RCA, PCI using a drug coated balloon, 275/30. You can see the result is quite good, right? After DCB. And LAD treated with stent and DCB using another brand. So it's a hybrid, is a stent proximal at the mid to distal is a DCB. But patient admitted for non-STEMI 1 year later. You can see there is restenosis over the RCA, but for LAD, it's okay. This area was treated with different brand. So not all the DCB are the same. There is no class effect. Different DCB, there are differences in terms of drug, the experience, the coating, the delivery system, and the drug dosing. This difference can significantly impact the efficacy and clinical outcome. So in conclusion, DCB in all de novo lesions should be is feasible and can be considered as a default strategy if there is adequate lesion preparations in large vessel, diffuse lesions, or ACS. DCB allows us to keep it simple and safe. There is no die-die DCB, especially in patient hemodynamic unstable in left main disease. We are allowed to wait and watch or bail out stenting if we are not confident with the result. Do more cases to gain confidence. Try leaving nothing or little metal as possible. With that, I thank you.
Hey, that's such a great demonstration of many various DCB cases, Chanting.
Yeah.
So I have to admit that I do get cold sweat looking at your cases. So some of your, probably majority of your cases, I will not put DCB yet, especially looking at those long dissections. So I would love to ask James to respond at Chanting's presentation, especially regarding putting DCB in ACS. Do you have any comment, James? Are you comfortable
Thanks for that.
Yes, DCB in ACS cases yet?
Thanks for that, Vishnu. Yeah, and thanks for the brilliant presentation, Chanting. It's great for you to share these amazing cases and tips and tricks of DCB in these unique scenarios. I kind of echo Vishnu's comments. I think I would admit that my current level of tolerance for dissections in these kind of situations is low, probably a lot lower compared to some of your colleagues and probably yourself. And the question in my mind is, in these large vessels and of course in ACS, in this proximal large vessels, when you're implanting a stent and you achieve optimal stent result with imaging guidance, large MSAs in non-left mains greater than 5.5, and we know that the MACE result, long-term MACE result, is low, 3 to 4%, and stent thrombosis probably less than 0.5%. So in my mind is, what is the added benefit when you're treating these lesions with DCB compared with stent? Of course, there are subsets where you may not be able to find the adequate landing zone, for example, or there's an issue with depth tolerance for the patient, for example. But that is kind of the question in my mind. But I think I'm learning a lot more as I listen to presentations from colleagues across Asia Pacific. But that is currently my practice. I think I'm still a bit more conservative.
Yeah, thank you for the questions. I think for us, why we are putting a lot of drug cortical balloons, because one of my consultants mentioned that your vessel look like a newborn. There's no metal inside. So for simple lesion, I think there's no difference between you are putting a drug cortical balloons or stent. But in complex lesions, I think if you want to upfront two stents or more metal, I think there's more complications. And in some kind of tortuous vessel, and sometimes you have some problems to deliver a stent. So in this kind of cases, in order for you to gain confidence in complex lesion using drug cortical balloon, in simple cases, you should have some tolerance to dissection first. If not, you won't be able to start your DCB journey.
Now there's a question in the Q&A section. One of the attendee asked whether a lesion is properly prepared when a smaller pre-dilatation balloon is used. Then they used a larger DCB to finish up the cases. Do you think this is a proper practice, or what do you think, Chanting?
For us, I think some in simple lesions we are pre-dilated using a semi-compliant balloons. So in certain semi-compliant balloons like 2.5, it can up to 2.75. So in 2.75, I think it can adapt 2.75 DCB or 3.0 DCB actually. So that is personally what I think. And especially for aesthetic vessel, actually I don't want to achieve like one-to-one lesion vessel preparations. I will be downsized because I worry about dissections in aesthetic vessel. You will end up with stenting with no stent size or there's more oppositions. Yeah.
But do you often use a smaller balloon size than a larger DCB, or you always use the same size balloon for pre-dilatation and DCB?
Okay, so if for me, cost is an issue. If I have two lesions I need to prepare, I will choose the size in between. If I only have one vessel to prepare, so I will treat it as one-to-one. It depends.
Okay, great. So next, we would love to ask Dr. Lamho regarding the use of DCB in ACS cases. What is your current practice? Are you currently using DCB in ACS cases?
I must say that my default strategy for PSI is still stenting. But now after the influence with many good fans like Dr. Tan and Homan Liu and other fans, Sandeep, I try to change to high beat approach nowadays, but still more on stent side. For ACS case, in my practice, definitely are still stent based. I'm not confident enough to change to DCB yet, but I think in some case I will try. The reason for me is that one is the evidence is not still evidence and guideline is still not enough. So in case of medical legal issue, I have some pressure. The second thing is about the mechanism. Maybe we can ask Dr. Tan to explain, because many of time in ACS case, they are caught in the coronary. When you use DCB, the drug just coat on the cord. When the cord dissolves, then the drug dissolves. So probably in acute phase, I may not consider DCB if there's large amount of cord. Okay. Yeah.
There's that one case when you put in ACS case and you put a DCB in proximal LAD. It's a large vessel. You can explain us a little bit more, Chanting, about your decision at that time.
That time, I think it's done by my other colleagues. I think she is very daring. Yeah, but I think if there is a haziness inside, sometimes we don't put in drug cortical balloons. It all depends on the flow actually. So in that cases, maybe there is distal myocardial infarction. That's why there is a competitive flow. But normally in normal cases, like if Dimitri, you should end out with Dimitri. If you after you putting a pre-dilatation, is Dimitri become Dimitru, you better put in a stent because there is a flow impedance impaired already. So if there's a haziness, you need to remove all the thrombus. Yeah.
So
we
Chenting,
have yeah,
sorry.
please, John.
Yeah,
Go
just
ahead.
a quick question, like just for the audience, because the experience, and I mean, sometimes we only show good cases and all that. Like from your experience, if you leave type C dissection alone and versus A or B, what's your, how often do you see them coming back in, like like in a, I mean, like more acutely and all that. So like overall in your experience, does type C tend to close, or you guys actually have seen quite a lot of type Cs that remain patent?
For our experience, actually, the type C, there's a in-out. So actually, most of the time, it doesn't close. So how long we wait, we keep our patient in our lab is about 15 to 20 minutes. So this is the time where acute closure will happen. So a few cases that acute closure happen, normally is the one that flow slightly impaired. There is an intramural hematoma. Type C usually in-out, no problem.
Sorry,
you
as
have
an
a question?
add-on to John's
Yeah.
question, do you leave the coronary wire there, Chenting, when for the 15 minutes, or you take out everything?
Okay, so for me, because I have only one lab, I cannot keep the patient too long on table. So most of the time, I keep my shift, and I will wait for the flow first. So the flow actually okay. I will remove everything and ask the patient to go to recovery. But if you think that the flow slowly impaired, better put in the stent.
I can add one comment. Nowadays, I use more and more. Most frequently, I use DCBs on CTO. I found that if you wire 2 to 2, you use DCB, the outcome most of the time are very good, provided that there's no significant recoil. And one additional finding is after the DCB on the main branch, for unknown reason, unknown mechanism, the side branch will improve a lot. I don't understand. I can't explain that. But this, I repeatedly found this finding in CTO.
I think in normal cases like main branch we treated with DCB, there's some osteolation. Actually, it become better. We see that before. Yeah.
Yes.
So we have two similar questions on Q&A section. It's about the duration of antiplatelets after the DCB-only strategy in ACS. Will it be 6 months or still 12 months? What is your current practice, Chenting?
Okay, for DCB in non-ACS, 3 months. It depends on how
yes.
long is lesion. If a lesion is very long and there's a lot of dissection, I will keep for 6 months. But for ACS, it's 12 months.
Yeah, still 12 months. Okay. So what about the situation in Australia, James? How many DCBs do you have? And sometimes cost is a big issue for deciding whether to choose DS or DCB, especially the price of DS has gone down a lot. But what is the current availability of DCB in Australia?
Yeah, that's a very astute comment, Vishnu. Yeah, I think currently the cost of drug-coated balloon is actually, as you're alluding to, is actually more than contemporary drug-eluting stents. So in some cases, more than double the cost of drug-eluting stents. So I mean, we do have various platforms of drug-coated balloons, and I think our use is steadily increasing. And I think, as Dr. Lamhose has pointed out, more often in hybrid situations where we tend to stent large proximal vessels where we know we can achieve a large MSA with imaging guidance, and diffuse distal disease, oftentimes a DCB is a great strategy for us. I think that the use is increasing, but I don't think we're nearly quite at the default DCB strategy yet. And cost is definitely a consideration still.
That's great. Yeah, as you said, not in every region or every country, the availability and pricing is the same, and it makes a huge difference. So last thing that I want to discuss with you, Chenting, and I think this should be a big topic in itself. It's about the use of imaging in DCB. because we have many people get different opinions. You don't have enough evidence. Some says just do imaging before and after. Some says no imaging after. What is your current practice?
For me, actually, imaging for me is to know what is my blood morphology, my vessel size, and normally if vessel size, if medial to medial, you need to downsize, not same, not the same. You need to downsize. If not, you will end up with very severe dissection and intramural hematoma and end up with stent. And the other thing is, do I have enough lumen gain or not? If there is a very tight stenosis, do I have enough dissection and lumen gain? If there is a lumen gain, I don't have the number, but it's a personal experience. If I have a lumen gain, actually I should have a good result. And at the starting, when I started using drug water balloons, actually I do relook the patient back about 6 months. And more relooks, the more I get my confidence. And now normally I don't relook back at my patients unless I have a special interest like osteo LAD dissections, I want to see back. Now I don't routinely relook the patient back.
Okay, that's great. So we still have lots of questions in Q&A, but I don't think we have enough time. So probably Chenting later can help to answer all these questions for very enthusiastic attendees. So do you want to wrap up the first session for us, John?
Yeah, thanks, Vishnu. Just a quick summary of this session, So I think for those of us who are planning to use DCB or who have used DCB, I think there are a few important points to take note. One is you need to really properly pre-dilate your lesion. I think if you talk to some experienced people, some people do just recommend just NC balloons or scoring balloons rather than semi-compliant. So that's something that we can take note of. I think imaging is important if you have it, because it really helps you to adequately size your pre-dilatation balloon. If you don't, then maybe you, based on your experience angiographically. With regards to the DCB itself, people do recommend holding it for slightly longer, more than 1 minute if it's not in a critical area and the patient's hemodynamically stable. I just want to caveat one thing, the Chentin Center is really very experienced, so they can, really push boundaries. I think for those of us who are starting, we may want to adopt a bit of a more safer approach and level up as you gain your experience. So I think the bits on the flow after your DCB is really important, whether to stent after. So good flow, you don't need to. If you have residual less than 30% stenosis, you don't need to. I probably recommend that, if you're starting off maybe a type A plus minus a B dissection, yeah, but C's you must be a lot more confident before you are willing to not touch it now. Yep, that's a quick summary of this session.
Thanks a lot, John. So I think we should move on to the next session. So next, we would love to invite Dr. Keh Yan Chan from National Heart Center Singapore, and he will be talking about coronary microvascular dysfunction, which is in itself a very interesting topic. So please, Yan Chan, do you want to share with us?
Vishnu, thanks so much for the very kind invitation. And okay, I'm going to be talking about microcirculatory disorder or dysfunction. And I thought it's a very pertinent topic, really, because in the APAC region, we are getting a lot more interest. I think there's a whole population that is in many ways undiagnosed. And at the same time, in this APAC setting, we have all these constraints like we were discussing for the same logistics of DCB. Is there enough resources? Is there enough cath lab time to do these procedures? Is there enough budget? And I think we're going to share with you our own personal experience. We've started doing microcirculatory testing in Heart Center over the past 2 to 3 years. As we've gotten a bit more experience, I like to think that I've gotten our time down to about, maybe if you're well prepared, 10 minutes to do this whole microcirculatory assessment. When John asked me to give this topic, I think there are a lot of terms out there. And I think instead of confusing ourselves and doing creating more technical terms, I really like this kind of motherhood statement. And the idea of ANOCA, angina with non-obstructive coronary artery disease, is really a motherhood statement. And if you were to Google this term, a lot of times they may point you to the JACC State of Art review in 2023. And this is really an excellent review. It kind of crystallizes the sort of phenotypes that you have and gives you a very in-depth session on how to start off on testing. Now, we are all very, very familiar with epicardial disease, but one important thing to really highlight is that epicardial disease really accounts for only 5% of the coronary circulation. So when you imagine a microcirculation, you imagine a reservoir that really accounts for 95% of the remaining sort of coronary circulation. And if you don't test for microcirculatory disease, you're really missing out on a lot of patients. Now, there are many, many terms, and because in the clinical practice, we can't have so many very technically difficult terminology and so forth. In my mind, I like to simplify into very simple phenotypes. On one hand, you have what you call microcirculatory angina, microvascular angina, or some people just use the term CMD. On the other hand, the other important phenotype to me is really coronary vasospasm. Now, coronary microcirculatory dysfunction or microvascular angina, if you think of it from a simple point of view, it's very much like having coronary artery disease of all this distal microcirculation. So there's a lot of theory about, capillary sort of rarefaction, sort of arteriolar hyperplasia, but really the mechanics are still, to be discussed. But thinking of it like a simple coronary artery disease affecting the distal microcirculation. And we'll talk a little bit more about all the diagnostic criteria. Now, the reason why I put a Venn diagram, and there's a little bit of overlap, but this, for practical reasons, is a separate entity to me, is because vasospasm is really very much a vasomotor disorder. It affects mainly the smooth muscles of the coronary arteries, be it in the epicardium or in the microcirculation, and it is very much, we say, endothelial dependence of phenomenon. It's a reversible condition, and it's very different animal to me to the distal CMD. I think quite often we get asked this question, why bother with CMD? Now, I'm just going to share with you a case. 45-year-old gentleman who I thought came in with NSTEMI due to LAD disease, as you can see based on the ECG and the echocardiography. Now, the angiogram is, to me, very disappointing. I was looking for a tight LAD lesion, but instead, at best, you see a mild to moderate sort of mid-LAD disease with a bit of myocardial bridging, and the RCA is otherwise normal. Now, the conundrum really is that because of the lack of information and clear diagnosis, you always have this dichotomy, what exactly do I do at this point in time? And I think for me, I'm going to try to hold your interest here. We are going to continue share what we did for this patient, and we're going to the theory of CMD. Now, these are all the challenges I think we all face in the sort of the APAC region, but I'm going to try to answer some of these questions. Now, the first thing that I always say is that you can't treat what you can't diagnose. So the very important caveat to CMD is that despite having normal coronary arteries, CMD carries a very significantly negative prognosis. And secondly, without a proper diagnosis for patients who come in with angina, I think that often we are plagued with readmissions, revisits to clinic, and the lack of treatment because the patient doesn't have a clear diagnosis. Now, to elaborate a little bit more on my point about CMD and its effect on the prognosis, I think there are a multitude of studies already, and repeated data, even in meta-analysis, show that your presence of coronary microcirculatory dysfunction gives you a much significantly worse major adverse cardiac event rate, despite the fact that the coronaries are normal. As we do more work, I think we realize that there are different phenotypes. I like to kind of highlight phenotypes such as those with low CFR, and these entities and those that have very endothelial dependent microcirculatory dysfunction, drop in sort of acetylcholine-induced blood flow. These tend to be more malignant phenotypes. But I think without even starting on CMD testing, it's very difficult to get to this point. So most of the lecture will be more focused on how do I get started off practically. The other question that even when I started doing CMD testing is that why not we just diagnose the patient clinically? If the patient has typical angina, if the patient has normal coronary disease, why not we just diagnose the patient with microcirculatory angina? Now, this 8 angio study actually shared with me and actually clarified a lot of doubts. This is a very interesting paper. It's an all-comers study to a cath lab in Spain, and really they took patients who were suspected to have ischemic heart disease in the outpatient setting and had come for coronary angiography. The angiography was done, and subsequently the physician was actually asked to label what was the diagnosis. Did they think in the absence of CAD there was CMD, and what was their treatment plan? Subsequently, they underwent sort of microcirculatory assessment. And as you can see, with only angiography, you are only able to get a diagnosis in the cath lab 30% of the time. But if you use microcirculatory testing, this increases your total yield of the cath lab to about 80% accuracy of diagnosis. You're able to pick up 30% of obstructive CAD and another additional 45% of ANOCA. To the question of can you identify ANOCA based on eyeballing? So there are some who believe that if you have slow flow, this is likely ANOCA, or if you have a certain phenotype of patient, this is likely ANOCA. But the data here suggests that 50% of the time, the physician is not able to accurately subtype the ANOCA. And this has huge implication on the type of treatment that is given subsequently. So how do we assess for CMD? I think the first thing really is a clinical. So when you think about CMD, this is sort of distal microcirculatory disease, and a lot of there's actually papers to suggest, and we see this in clinical practice, patients tend to present with exertional angina. Conversely, as we mentioned just now, vasospastic angina is sort of a transient phenomenon. So patients present very much like unstable angina. The additional hint is that they may not have as much classical cardiovascular risk factors. And a lot of this angina is kind of triggered by emotion, by change in weather. Some of my patients tell me that they get this angina at night when there's a change in the weather or they come out from a cold shower. On the other hand, microcirculatory dysfunction is one where you suspect typical exertional angina in the setting of, risk factors. And we've shown in terms of studies that a presence of a positive stress test with typical symptoms and a normal coronary arteries is very suspicious of CMD. Now, let's go into the details of how we test for CMD. And again, this Venn diagram helps to think of these two separate phenotypes and the equipment you're going to use. Now, for microcirculatory dysfunction or microvascular angina, you're going to need a couple of devices. First, you need the Coroventus system, which is the only commercially available physiology system that assesses for CFR and IMR. It's very useful because these numbers actually come up concurrently with FFR, so it doesn't take a lot of additional time. You use the pressure wire X, which is connected to the Coroventus, and for hyperemia, ideally, you will want to have IV adenosine. However, in a setting where you may not have IV adenosine, there are papers to show that intracoronary adenosine or intracoronary papaverine are reasonable alternatives, if you don't have it in your lab. Now, those of you familiar with fractional flow reserve will find CMD testing a piece of cake because this is essentially the same test. One important hygiene point is that you want to ensure that your guide catheter is well engaged to the left main. Just like how you give intracoronary adenosine, this is a thermodilution-based procedure, so you want to make sure that all the fluid you give goes right into your coronary arteries. The other sort of key to this is that when you're doing CFR, especially towards the end of the procedure, patient tends to get very restless and there's discomfort, and you may not get the adequate reading. So I suggest doing resting CFR or the resting sort of index early. You choose the option of doing CFR and IMR here after you've run a quick RFR run, to make sure there's no significant epicardial disease. And I'm going to show you a video, and this is basically a thermodilution. You take 3 cc's of saline from your manual injector or your galley pot, and you inject this very briefly. You can see this particular injection I gave wasn't as robust, and the computer will actually prompt you to repeat the injection. And very quickly, you're going to get 3 readings. And from there, the system is going to prompt you to induce hyperemia. So after 2 minutes, when you induce hyperemia, this is basically you just repeating the bolus thermodilution again. So in my mind, this is an additional 2 to 3 minutes to your actual regular FFR procedure. Once you've completed this, immediately when you click calculate, you are actually given all these values. And it is a bit crowded, but you kind of want to make sense of things in a very simple, targeted manner. I usually start with the coronary flow reserve, which is basically your ratio of coronary blood flow during hyperemia, which is denoted by the hyperemic time, versus your coronary blood flow at rest. So this is kind of like doing a cardiac output and getting a ratio in that way. So the coronary flow reserve, there is a sort of a semi-arbitrary cutoff of 2 to 2.5, but the idea is that a low CFR is associated with a poor prognosis. A high CFR is, generally a good prognosis. And CFR just tells you that there is a disease, whether be it in the epicardium or in the coronary microcirculation. The index of microcirculatory reserve, the analogy is kind of like your PVR for your pulmonary hypertension. So those of you who are familiar, this particular formula is basically the distal pressure times your hyperemic time. And by this index, the cutoff is given as 25. So an elevated index, just like you have an elevated PVR, denotes that, it's likely you have microcirculatory disorder. So these are pretty simple numbers. And once you're familiar, interpretation is very fast and quite a piece of cake. Now we're going to switch gears. The next bit we're going to talk about vasospastic testing. And really with vasospastic testing, there are two basic important contraindications and things that you don't want to do is give this with someone with poorly controlled asthma or significant AV block. In all other situations, I think it's a very, very safe medicine as long as you abide to simple rules. And one thing I actually, for the purpose of this lecture, I actually asked our pharmacists, how much does a vial of acetylcholine cost? And you realize that this is not an expensive medicine. And I feel strongly that we are not doing enough vasospastic testing because I think this helps with the diagnosis. I would just flash this slide because each acetylcholine has its own dilution protocol. If you get acetylcholine, I think you should work with your pharmacist to derive a protocol to dilute the acetylcholine. What we've done is a very simple protocol that ultimately results in very small doses which are simple to use. I'm mathematically challenged, so I don't like very weird numbers. So for us, we start with a small bolus of 10 mics, and then nowadays I've done away with 50 mics and go straight to 100 mics. That's just my personal preference. What you want to do with acetylcholine is two things. The reason why you start at 10 mics is really because there are rare cases of acetylcholine hyperresponders. You see one in maybe about 50 or 100 cases where at low doses, patient develops severe spasm. And already that's your diagnosis, but you don't want to give a higher dose. The second thing is that you're going to give this as a very slow bolus over 2 minutes. And after which, even after you've given it, you actually flush in very, very slowly. You watch the ECG carefully, mainly for AV block. And really the diagnosis is the patient has reproducible chest pain, ECG changes, and a 90% stenosis. Now, in the interest of time, we can discuss this later, but I think this is a bit more technical. I'm going to share with you what we did for the case. So if you remember, 45-year-old guy with non-ST-ACS and very suspicious looking LAD. And as you can see on the OCT run, that there's no signs of plaque erosion, thrombus, vulnerable plaque, corresponding to this mid-LAD segment. So we gave this patient acetylcholine. It just took us an additional 5 to 10 minutes. And as you can see very severe reproducible epicardial 90% spasm with classical chest pain and ECG changes. So this was the diagnosis. We diagnosed this patient with epicardial spasm. And for those of you who are worried about giving acetylcholine, you just have to have GTN on table. So immediately after we see this, we give GTN, and within 1 minute, the spasm goes away and the pain resolves magically. I've never had a case where the spasm comes back after you give GTN. So this patient has been on follow-up with us for 2 years. He has not required another A&E visit. So that's something very important to highlight. My second case is basically a lady with unstable angina, new onset. And geographically, I'll just speed through this, but essentially, I think other than a very proximal LAD sort of moderate stenosis, I don't see any other critical lesion, and the right coronary artery was fine. So to assess both the LAD lesion as well as the microcirculation, we perform the Corventis assessment. And as you can see, the CFR is severely impaired, suggesting there is a distinct problem in the blood flow that can account for patient's symptoms. But the epicardial lesion is not hemodynamically significant, and you can see the IMR is significantly elevated. So the diagnosis is CMD, and this patient is not treated with stents, but with medical therapy. Now, for the treatment of CMD, it's another separate lecture, so I'm just going to highlight a couple of important things. I think of these two subsets differently. So the CMD subset, it is very much a systemic disease. So lifestyle modification and perhaps medicines like statin and aspirin will help with long-term benefit. For symptoms relief, I think there's data to suggest that from small studies to suggest that ACE inhibitors, ranolazine, and beta blockers may be helpful. For vasospasm, they tend to respond really well to dihydropyridine calcium channel blockers. Nitrates are a second line because of tachyphylaxis. So I'd like to wrap up by saying that I think it's been a very interesting journey, and I'm actually looking forward to panel discussion because there's a lot to learn in this field because we are all still in the early stages of our understanding for CMD. Thank you very, very much.
Yeah, thanks, Yin Chan, for really very comprehensive lecture in like 20 minutes. So maybe we'll just take a question from the audience. We have on the Q&A for the vasospastic test, do you do it for the left or the right side, or do you need it for both? And is there any role for antiplatelet, if it's positive?
Yeah, so that's a great question. I think routinely I do it for the left, basically because based on time sensitivity. The right can be done, and it's been shown if you do it for the right, you pick up an additional 20% of the cases. Some of logistic issues about the right is that they tend to get very bad bradycardia, if I'm not wrong. And the centers who do it routinely, some of them even put in a TPW, which adds to the logistics of it. So I do it routinely for the left, and that's what is suggested as well.
So maybe I'll start with a question because people times often have this misconception that, for example, if you have microvascular disease, the non-vasospastic kind, are there really any good treatments that have been shown to be effective? And there are actually maybe two different types of non-vasospastic kind of microvascular disease. How do you differentiate them apart? And what kind of medical treatment would you tailor for each of the different types?
Yeah, so that's an issue of ongoing research at the moment. In my mind, there are two things. I think that this is one, I think this is just personal opinion. The CMD, especially structural CMD, behaves very much like your ASCVD, and that's why your MACE rates are pretty high. And for those reasons, I think aspirin statins are probably beneficial more for long-term benefit. In terms of treatment, in fact, the only randomized trial, if I'm not wrong, for treatment is actually with ACE inhibitors. And that's a small trial. It does show that there is some there's significant improvement in symptoms relief. There are smaller trials for ranolazine as well, and if I'm not wrong, amlodipine. So all of these things are known to reduce symptoms. But in terms of hard endpoints, I fully agree. As of now, there's no sort of established treatment. Phenotypically, there's distinction between sort of structural CMD and functional CMD. So structural CMD, as we mentioned, behaves more like your atherosclerotic disease in my mind. For your functional CMD, maybe behaves a little bit more like your vasospastic disease, the endothelial sort of dependent disease. So in those cases, maybe nitrates and calcium channel blockers may be helpful. But as of now, it's actually challenging to differentiate between the both.
Maybe I will open this to our panel, James as well as Lam Ho, how do you approach microvascular disease testing, in your patients? Is there a type of patient that you will do it, or do you do it blanket? If you see normal coronaries, you just proceed with this. So how do you select patients, on the table for microvascular testing?
Yeah, thanks for that, Jonathan. Yeah, I think it's increasingly recognized, as Yin Chen has pointed out, increasingly recognized contribution of debilitating symptoms in a lot of our patients with normal epicardial coronaries, and then we're increasingly thinking about microvascular testing. In fact, I think a lot of Australians did a lot of work in this space. Andy Yong, Martin Ng, in terms of the IMR, and also Tom Ford, actually, who is also an Australian cardiologist, published the Core-MICA study back in 2018, which is another randomized trial looking at stratified treatment for patients with vasospastic versus microvascular angina. And as you guys pointed out, I think it's also for symptomatic treatment in terms of the treatment endpoint. So no hard endpoints proven. So really, I think at this point, selecting patients, if they have a clear history of angina, ECG changes, but normal epicardial coronaries, I think you should be starting to think about these type of tests. And if you do, it should be a comprehensive assessment, both for CMD and for vasospastic angina.
Yeah, so just for me, I'm probably somewhere in between. I actually do look quite closely at the history, so as James mentioned, if the history is suggestive and the coronaries look normal, that's one kind of suspicion that, would trigger a possibility of testing. And the other bit that really kind of I find very useful is, if you have a functional test done before that's really abnormal, it can be a stress echo, it can be a stress myocardial perfusion scan, it's abnormal, and yet you have a really pristine kind of coronaries, and that should kind of trigger, that there could be some underlying microvascular disease. Lam Ho, maybe can I ask you, what's your experience with acetylcholine, challenge? Do you do it routinely, or how often do you do this?
Yeah, I must tell you that in my hospital, we usually do not do this test because it's very dangerous and terrible. I learned it during my overseas training, and I see how they did it, and there are many, many astonishing and terrible experience. I see some case you just inject and then patient VFRS and then CPR and after that I get some trauma. And then that's why I do not develop this in my hospital. I mainly make it by clinical, maybe due to spasm or whatever, just medically manage, clinical manage, but not try this test in my hospital. Yeah.
So, yeah, maybe Chen Tin and James, do you all do acetylcholine challenge, and how often?
In Malaysia, I don't think any center have the microvascular testing yet. So we just treat based on the clinical suspicious. So if the coronary is quite normal, patients still presented with symptoms. So sometimes we just blanket give medication and see how it go. But recently, we see quite a lot of like QFR come up with some IMR testings. What is your thought about that?
Yeah.
Shan, do you have any experience with that? No, I don't think so.
Yeah, I did when I was overseas have a look at these systems. My 2 cents is I think they're still maybe not as close to the wire-based indices as we would like them to be. But it's a good start. I would love to have a system where I don't need to float a wire down, but I'm not sure it's as close to ideal as we would like it to be.
Yeah, Jonathan, I guess at our center, yeah, we do have a protocol for microvascular and vasospasm testing. But yeah, I think it's not, I wouldn't say it's a routine. I think we're quite selective with our patients. And also with microvascular testing, I think currently it's a lot of it is in the research space as well. We are involved in some research, multi-center research studies using the IMR testing after primary PCI. So so we have a lot of experience in that regard, but vasospasm testing, I think we're more selective.
Maybe a question more open to everyone, there's a lot of interest once again in treatment when evidence is a little bit lacking, but just really interested to hear everyone's experience. We have a question on the Q&A. So for a suspected case, or let's say, you really think this is a likely coronary microvascular dysfunction, do you start a combo kind of treatment, or do you start one drug first, see how it works? Or what's everybody's experience? Maybe Vishnu?
So I think the current situation is similar to like in Malaysia. So it's sometimes the modalities are available, but it's only when a vendor bringing a sample. So it's not available on a consistent basis. So when you have a suspicion, then probably you will very rarely you will do invasive measurement. You will just do probably an MRI or nuclear perfusion. Then you do blanket therapy. And sometimes it works, sometimes it's not. But I think that's all what's available now.
For me, I will
So
just use single antiplatelet and then will control the lipid and glucose well. I think SLT2 is good. And in my experience, I think nitrate usually will not work. I usually will try Vastro MR. That's my limited experience because those cases are not very common.
so I sometimes I will also suggest for an ECCP therapy just to induce the microvasculars. So I'd love to ask Yanshan whether you have any data of a comparison between an invasive CMD measurement and probably like MRI. Is there any comparison data?
No, we are actually part of a trial, in fact, that also correlates, try to correlate between the two, but I'm not aware of any local data at least. But as to the question you asked, I think there's another question on the chat group. Yeah, so you can also use the cardiac MRI, and there are sort of MRI changes that suggest sort of microvascular dysfunction on the cardiac MRI. But if the patient's already on the cath lab table, then sometimes you have the additional benefit of getting it done at the same time.
Yeah, and
So
also
one,
with MRI, it's really difficult to evaluate if it's a spasm, right?
Yeah, I don't think it's possible. It's not possible for vasospasm. It's more for the sort of anatomical CMD, which is the microvascular angina, yeah, that has some MRI changes.
Okay.
so back to the point, in some of the resource scarce settings, where you do not have the ability to test on invasively for coronary microvascular dysfunction, this can be a surrogate. So as Yan Chan mentioned, if you have it and patient's already on table and you suspect it, it probably is good to do because it will kind of help in your management of the patient, especially if someone who has been recurrently coming to see you for chest pain. In the event you do not have it for example, in some countries, I think some surrogates are useful. Like I personally, if I see a CT chorus that's fairly normal, and or the patient underwent a coronary angiogram that's normal, and as I mentioned before, you have some form of functional testing, it could be a positive ECG or positive stress echo or positive kind of a stress test, then you know that, and symptoms sound fairly suggestive, then I think it's actually quite all right to actually trial of medical treatment with regards to microvascular dysfunction, and then you see whether the patient responds. And if not, you can kind of switch accordingly. It's a bit of experiential kind of based kind of treatment. Mm. Does anyone has any other comments or questions? Like I've heard some people say, there was just a comment earlier, like if you are not vasospastic kind of angina and you give nitrates and all that, there's some tendency that you could make things worse. Yan Shan, you have any comments on that?
Yeah, in fact, two things are one, I think if you have vasospasm, things like beta blockers, in fact, make things worse. Even the nitrates, the tachyphylaxis is a major issue. So now I think other than microvascular angina, I try to avoid nitrates. They don't seem to work very sustainably as a long-term therapy. So that's where your phenotyping really comes in handy. And also I think Dr. Lam made a very good comment about, the safety of acetylcholine. I've been doing for the past 2 years, and I like to think I do a fair number. So I do maybe 1 to 2 cases a week on, as John says, selective basis. But by doing very small doses, doing carefully and monitoring, giving very slowly, never had a case of VF. Maybe out of so many, maybe only one has sort of significant spasm, and that resolve very quickly with a lot of GTN. So I think it can be done safely in fact, in the APEC setting.
Yeah, so with regards to acetylcholine testing, if you have that available, I think really important to really have backup standby. I mean, there are all those rare cases of disasters that we have heard, but I think, as Yin Chan mentioned, if you do it meticulously, in increasing doses, you have a good protocol, and obviously you have standby things to bail yourself out, like including, microcatheters that can go down and inject. Because, when the vessel closes off, you inject through the main guide, your GTN, you may not go down, so you may need like a thrombustor, something quickly over the wire to inject your rescue medicine. So if you have that standby, it tends to make the testing a lot safer. I think we have one more question. Then maybe we will close after that. So one of the attendees mentioned that in evaluating the cause of recurrent chest pain, and your angio is pretty equivocal, and you still need to check whether it's vasospastic or microvascular dysfunction. What do you do first? Do you do the basic bit first before you finally inject acetylcholine, or do you do the acetylcholine first? Yeah.
Yeah, so this is actually a subject of long debate. Because if you give your traditional CMD testing first and you need to give GTN for the wire spasm, it actually tends to affect your vasospastic testing. So what I've done recently is that I start, as you can see, for the CMD testing with the resting index first. Then I do it without GTN. You do the vasospastic testing next. And while your coroventis is still on, then you induce hyperemia after you've given GTN to reverse the effect of acetylcholine. And you're going to start adenosine, which further vasodilate the patient. Then finally, you do the hyperemic bit. So it's resting flow, vasospastic testing, and then hyperemic flow. And that's my personal sequence nowadays.
Thanks a lot, Yanshan. So I think we should close up this session. It's been a really fruitful session. I personally learned a lot. And I see at our peak, at the peak time, there were more than 250 participants joining. And they're quite enthusiastic. More than 12 questions has been raised in Q&A session. We would love to personally to thank Medtronic and Abbott for supporting this session. And also would love to remind everyone to again join our next APSC Hot Topic session. It's in the 5th November. It's about cardio-kidney metabolic syndrome. And therefore, I would love to personally thank Chanting, Yan Chan, and both of the panelists, Dr. Lampo and James Su, and also my co-chair, Jonathan Yap, for another very interesting session. So thank you all, and